Welcome. I am Rachel Lowy. I'm a clinical psychologist by training, faculty at UCSF. I'm going to talk a bit today about one of the early parts of developing a CSC program, which is really around eligibility and then screening. How do you get folks in? One of the pieces of feedback we've been getting from a lot of programs are that, on the one hand, if we look at incidence data, we know that there are lots of folks who need this service. But then when you set up all of these intensive services, somehow it's very difficult to find the right people for your program. And so we're going to talk a little bit about some potential solutions to that. Some of you have programs that have been in existence and running for a while, in which case some of the slides around eligibility are things for you to just think about. How have you as a program decided on your eligibility? What's been working for you? What hasn't? Some of this changes over time. And for new programs that are developing, I'm going to just lay out what are some of the things you need to think about and decision points to walk through that you'll need to make. So this is sort of what I said. We'll talk about eligibility criteria, talk about universal screening and how that can work for you or other ways to use screening. And then get a sense of the referral and screening process, which is extensive. There's many steps along the pathway to actually getting someone into coordinated specialty care. So we want to think about that and how we can support people through it. So one of the first questions that you're going to have to ask yourselves is, do you want to serve first episode? Do you want to serve clinical high risk, or both? And hopefully everyone here understands, but I'll describe very briefly the way we think about the difference between these two groups is a first episode of psychosis. Someone has passed the threshold of saying, this experience I'm having, I am absolutely convinced that it is real, and you can't convince me otherwise. An example would be someone says, that voice is the devil talking to me. I'm scared. I feel like I have to do what he says. And no, I don't think it could possibly be anything else, right? That's the threshold of full psychosis. Alternatively, someone having these low-level symptoms suggesting there's risk for a psychotic episode, this clinical high-risk phase includes symptoms like, I hear something, I can't tell what it sounds like a voice talking, but I'm not sure what it's saying. It scares me. I don't know what it is, right? There's not a fully formed idea about what this experience is. So just to kind of describe a little bit, and I'll look to the group later for some of their own experiences, the evidence base really is there for first episode psychosis to be treated by coordinated specialty care, the RAISE study, other studies. This is a higher need group in a very critical window. I would strongly suggest this is where you start. This is a high need group in your system. It is challenging sometimes for referral sources to understand what you really mean by this early. For those of you who have programs that are running, you will have noticed that you got a lot of referrals in the beginning of people who were young, but had been having psychosis for a long time. So wrapping their heads around the idea that actually this is a specialty service, you only take certain people, that alone is a big jump, right? From how typical outpatient community mental health works. Usually it's, you have some sort of serious mental health issue and you live in this zip code. That's it. Great. So just having the idea of criteria and you say no to some people is really tough. It's a shift. And then the idea that someone who is maybe only 20 years old, but they've had psychotic symptoms for 4 years and isn't eligible for the early psychosis program is a tough concept for folks. However, the evidence is very strong that the impact of CSC is best the earlier it's initiated and the strongest within those first 18 months. So the challenge of saying no to some people so that you can say yes to others is really part of setting up a service like this. In terms of thinking about clinical high risk, in a lot of places start out serving both. That is certainly something that you can do. It's a bit of a more complicated diagnosis. In some ways, it requires a certain, we use the SIPs mostly in this country, the structured interview for prodromal syndromes. to come up with the diagnosis around this group. Keep in mind, people with this clinical high risk syndrome, a third of them, 1/5 to 1/3, are likely to develop a full psychotic disorder within about 2.5 years. So it's a very high risk group for a psychotic episode compared to the general population. But 2/3 do not. So many of these folks certainly have a lot of needs and a lot of mental health issues, but it won't necessarily become psychosis. It might be something else. It might stay at that low level. It might remit. That's the kind of group we're talking about here. Overall, they tend to need a little, somewhat less intensive services overall. Certainly there's variability. And as we've mentioned, the medication management approach is different. Other elements are fairly the same. It's just tailored towards this earlier stage or different group. It's entirely possible for one team to see both. And some programs like that because there's a little bit of a balance between some of the higher acuity first episode folks and some clinical high risk folks who also tend to be younger. So you definitely need to be thinking about age and your capacity for thinking from a developmental perspective, because these will be adolescents and sometimes younger adolescents. It also can be a little more complicated for staff, right? If you're starting out brand new, to grasp that these are not exactly the same population, they're a little different, but it can allow you also, if your new program starting, to fill your capacity more quickly, if that's something that you're struggling with. And I mentioned the balanced caseload. So those are some basic pros and cons. There may be others. Some programs have found that it's easier to start with first episode and then add clinical high risk at a later point. That's another option. This is something to sort of think about. Another piece of eligibility is how long someone has had their psychosis. We're not talking about truly a first episode. Is not exactly the definition, right? It's really how long has it been since the start of their first fully psychotic symptoms. Typically, programs choose 2 years. That seems to be, like we said, because that 18-month window is so important. So it gives us about 2 years. Some programs have found that it's difficult in their system to, like I said, really get referral sources on board with how tight that window is. And so starting with 3 years with the plan to move down to 2 has worked for some folks, but you really have to have that plan to shift down. Sometimes people have gone for a very narrow definition where they are seeing primarily clinical high risk and those with a first episode, as long as it's within 6 or 12 months of onset. So the focus is shifted downwards a little bit. These are all different options. It will impact both your recruitment as well as thinking about your services. Even though it's overall the same team, the emphasis may be in different areas. For example, the younger you go, obviously you're going to be working a lot more around schools, working with schools, then you will be thinking about getting people into competitive employment. So those are some of the impacts. We will emphasize the importance of involving family, no matter what the stage is. But obviously, a 12-year-old living at home with family is a little different than a 25-year-old who doesn't want family involved, and yet we know they might be a support. So those are different situations. What kinds of psychosis, right? It's not all the same. So the narrow definition would be schizophrenia spectrum disorders. And that's where some of the research data comes from, right? A narrower definition that has the strongest evidence base for being effective. However, we know that just serving a very narrowly defined population doesn't then serve all the people with psychosis that we could be helping. So many programs say as long, essentially, as there is any psychotic symptoms, it doesn't matter what the DSM-ICD diagnosis is. We're not interested in that. And others fall somewhere in between. And I think this middle group is probably the most common, where primary psychotic disorders and then mood disorders with psychotic features. Sort of somewhere strikes the balance in between. Some elements that you will need to grapple with, and these are not things that are simple. They can evolve over time in terms of what you're able to do. How much substance use is okay, essentially, right? So hopefully we've all moved past the point of thinking that substance use treatment, dual diagnosis, these should be separate treatments. However, the question is how much, right? So some people will say if it's a strictly substance-induced psychosis, this is not the right place. If the person only has psychotic symptoms when they are using or coming down from a substance, or something like meth can last a while, then we wait to see if it clears up and there is still psychosis. Some people would say, it's really hard to tell with this population. There's a lot of substance use. It's all mixed up. We're not sure. We'll work with the person. And if over time we discover that really their psychosis clears up and that isn't the primary issue, then we'll see about transferring them elsewhere. But right now they're having psychotic symptoms, so we can help. I'm trying to describe sort of, the two ends of the approach. And then some people are in the middle, and it really has to do with how much can this person engage in treatment and is willing to try to engage in treatment. Obviously, if they need a higher level of care, like residential substance use treatment or something else, that's a more appropriate place for them. But most people are really in that in-between stage of their using to some level. Obviously, it's making their psychotic symptoms worse, but you can't quite tell what's what yet. People tend to exclude diagnosed intellectual disability with an IQ below 70, which really just means when it is documented and clear. Some places actually do assess IQ, but those tend to be university settings. That's not really likely to happen in many community settings. These are folks who have been excluded from pretty much all of the research on early psychosis. So it does not mean they couldn't benefit from CSC. We just don't know. This is a tricky piece. Age, as I've said, which is going to be driven quite a bit by which first episode or clinical high risk or both you're seeing. Some people stick to a transitional age youth definition. Some are more broad, 12 to 30. As Tara mentioned, they go up to 40 in her group. There is evidence that the onset for women tends to be a little bit later than the onset for men. And so by sometimes expanding upwards, you're capturing some of those women with a later onset of a first episode. Those are things to consider. And these are also, as I said, a lot of programs will come up with their eligibility criteria at the beginning, and it can evolve over time. You also have to see how you fit in with your system. What other services are available to folks or are not, and how do you fit so that you can cover what's needed while still being true to your mission. I describe that as the challenge. Neurological causes are typically excluded. So for example, if someone has temporal lobe epilepsy and the psychotic symptoms are really related to that and it's clear, they would this might not be the place for them. Again, that's a decision that you would have to make, and you would have to mostly rely on records as well as making sure people are getting the evaluations they need with neurology if that's a concern or a question. And that's certainly something we can talk about. How do you interface in making these criteria decisions with making sure people are getting the assessments that they need, and we're not just making assumptions about causes. That's an important point. And then, of course, level of care. These are outpatient programs. Yes, they provide more frequent or intensive services, but they are not residential. They are not day treatment. That's not the level of care. So you have to see what people need. So I'm going to switch a bit to screening. And I always use this. I've been using this, I think, 20 years. This is an ad from the peer group in Maine. And it reminds us that if we don't ask, we won't know. There are so many people seen in mental health services who have psychotic symptoms, and their providers have no idea. So when you start working in early psychosis, I think people are mostly thinking of very clear cases of overt schizophrenia, right? But really, there are many, many people, a lot of them, this is a younger kid, but really teenagers or young people who are aware that psychotic symptoms carry a lot of stigma. They're afraid to be honest about them. They're getting treatment for depression or anxiety or trauma or something else and never say a word. And if you don't ask the right questions, you will not find out. So what happens is providers will sort of conceptualize this person as, oh, this is a depression issue. Maybe they asked a few questions at the beginning of treatment, and then really that's it. I've heard this story so many times when we ask people about their pathway to care. They saw so many different counselors, so many different providers. Nobody knew the psychosis was going on. They were scared to talk about it. They were afraid that that would mean that they would be put into the hospital, or that people have all kinds of ideas. I've heard patients say psychosis means that you're dangerous, right? They know these same stigmatizing ideas that the general public holds, and people are scared. So thinking about how do you assess for some early signs is something to consider. So a lot of the work that we've done is developing a brief screening self-report measure. Some of you may be familiar with it, the prodromal questionnaire, that was originally meant to get at the clinical high-risk symptoms. So you'll see the wording of these items is pitched not at the fully psychotic level, but at the more subtle level to try to get some of that information from people, especially because providers in outside of specialty mental health, early psychosis work really have no idea how to ask about those more subtle symptoms. And so it's very helpful for providers to have a way to do it, to start the conversation. It makes them feel more comfortable following up on those questions. So that's also something that's helpful. So here's just an example. We're asking about experiences in the past month. First, yes, does it happen? And then how much distress or impairment is associated with it. So this is the difference between an experience and a symptom, right? We don't want to be pathologizing normal experiences. And some level of what we would consider psychotic-like experiences are actually quite common in the general population, especially in adolescence. We also don't want to be confusing what are culturally appropriate experiences or other things. So it's the key is that it causes some sort of distress or impairment for the person. So we have a cutoff of a distress score, which means you add up how much distress and impairment they have for items they've endorsed. That a score of 20 or higher is highly related to having a clinical high risk or a first episode or a psychotic disorder diagnosis. We developed the measure by also trying to get rid of some items originally that were endorsed at very high rates just in a general population. The measure is available in about 20 languages at this point. It is possible to translate them into more. And we did a study in Sacramento where the questionnaire was put on a tablet and administered during the intake process to general outpatient community mental health, as well as in some school mental health, school counseling centers, or centers that were really built around educational needs. And those who scored above the threshold were referred on to an assessment with the EDAPT clinic at UC Davis, compared to the same kinds of sites who didn't use the screening tablet and just were educated on what signs to look for and could refer cases the way they usually would. Here are some of the results. So I'll walk you through this. What we see overall is, of course, with the screening, we get many more people referred. Now, the blue is much bigger. So what you'll see is those are false positives. Those are people who did not have psychosis. So you do end up at least talking to a lot of people where there's something else going on. Now, These were not people, of course, who had nothing happening. These are a lot of cases sometimes where there's a difficult differential diagnosis. And what we found is that the referring sources actually find a little more assessment of those folks very helpful. So it can take up a lot of time. You have to be careful, but it also can offer something of a service to the system. That's the trade-off. What did we also see, of course? So I want to highlight that there are a lot of false positives. You have to be ready for a lot of calls to come in. You can get busy, but look at how many people were identified who actually were clinical high risk, the yellow, or this grayish color first episode, and even some people who had had psychosis for longer than 2 years and otherwise, weren't really getting picked up or identified as such because they were supposed to only screen people that they didn't know already had psychosis. So this tells you who in the system is there and not getting picked up. So, like I said, the number of positives is high. So 1 out of 7 people who completed the tablet reported some sort of psychotic-like symptoms, which of course are experienced in a wide array of disorders, right? You can have someone with OCD or PTSD who has psychotic-like sounding symptoms at the edges there, but that's not really a primary psychotic disorder. But we definitely found a significant difference in our screening group compared to our relying on typical referral. You can get fancy and put this on tablets so that there's centralized data collection. You can use paper and pencil. I mean, there's different ways you can implement this. And when we think about the process, there are ways that you can translate that high number of false positives so that it doesn't flow all the way through to meaning you have to do a full evaluation for every one of those people, right? So one way that it's done is that at the referral site, someone can fill out a PQB, or they can do it online on a website themselves. And then there's a referral form saying, yes, this person scored high. Here's some information about them. And then this phone screen with the provider is really key. This is where you have someone at your program who is fielding the referrals, who really understands very well the criteria for your program and how to diagnose someone. This is not your front desk staff just checking some boxes. This is a clinician, someone who has a decent amount of training, who can screen out those folks who really need services elsewhere and are very unlikely to be within this psychotic spectrum. So you might talk with the provider, with the consumer, with their family, and then have an intake assessment. So that's that stage that can help with that high rate of false positives. So you're reserving assessments, full assessments for people that are very likely to qualify. And that, of course, used to be in person, can now be in person or remote, however you're able to do it, whatever works for the family. And then there is usually discussion. Not just some programs do rely on someone to make a decision, but ideally these are being discussed. These are complex cases and there's a team discussion. And then very important, the feedback that you give to the young person and their family in either case, right? This is not just oh no, you're not eligible, go back to the clinic you came from, right? We want this to be therapeutic. Some discussion of what you do think is going on, because you've just collected a lot of information, feeding that back to the referral source as well about what you do think is going on, what you might recommend. That loop is very, very helpful to the system and is likely to increase your referrals because people find that process helpful, even if they don't qualify. And if they do, of course, then we have there's lots of training available and materials about how do you have those conversations with young people and families about what's going on, right? What words do you use? How do you stick close with their experience while also helping them put together the picture of what's happening and do it in a way that gives them hope, right? Too many people have been told, oh, maybe it's schizophrenia, maybe it's psychosis, with the implication in their words or in their nonverbal cues that that is a terrible thing, right? So we want to think about how do you give that feedback in a way that's supportive and that points out that early intervention can be so helpful and that recovery is possible.